Hi, everyone. It's Stephanie with the Patient Story. Hope you're doing well, wherever you're joining us from. Good morning, good afternoon, good evening. I'm really excited to bring back one of our guests who has been on before, so great at explaining things in human terms, which is how I understand things. So, Dr. Joshua Richter, welcome back.
Thank you so much for having me.
And as many of you know, Dr. Richter is director of multiple myeloma at the Blavatnik Family Chelsea Medical Center at Mount Sinai in New York. And we have a lot to get through today. You've come, back, or you attended. I mean, people did virtual, people went in person. There's this hybrid conference, but it's the big blood cancer conference of the year. And so, for you, what were kind of the big takeaways, the big highlights?
There were three big topics in myeloma that everyone was talking about therapeutic wise or treatment wise. Those were the bispecific antibodies, and we saw some great updates from a number of bispecifics, the CAR T cell therapies, specifically cilta-cel, which we're hoping for approval very soon, and the cell mods, the kind of next generation drugs like Revlimid and Pomalyst, a drug called iberdomide. And we saw updates from all of these. These were absolutely amazing.
So again, it's promising for multiple myeloma patients and their families, and we will stay tuned. But you mentioned bispecifics, which I think are of great interest for a lot of people. So if you could give us a quick lay of the land again, what are bispecifics? And then we'll start hitting some of these updates.
Sure. So many people with diseases like multiple myeloma and non-Hodgkin's lymphoma may be very familiar with antibodies or monoclonal antibodies, drugs like Rituxan or rituximab or Darzalex, which is daratumumab. And just like our body makes antibodies to fight infection, in the lab we've developed antibodies that fight cancer. And cancer cells have these markers that stick up on them, and we basically have these drugs that latch onto it and try to kill the cell. Well, that's all well and good, but bispecifics take that to the next level. So we all know that the best cancer fighter there is our own immune system. It protects us from most cancers on a day-to-day basis. So the concept of a bispecific is not only to directly attach to those cancer cells, but let's activate our own immune system to attack better. So bispecifics have two parts to them. One part attaches to the cancer cell, and the other part attaches to our own T cells and activates them to attack the cancer. In myeloma in the clinic, we have four different targets for this bispecifics to attach onto on the cancer cells. Something called BCMA, B cell maturation antigen, on all the cancer cells. We have something called GPRC5D, something called FCRH5, and something called CD38. And all four of those are independently expressed on cancer cells or myeloma cells. And the other part is attaches to CD3, and CD3 is on all T cells. So you grab onto one of those four on the myeloma cell, grab onto your T cell, and they fight each other, and the immune system wins.
So first, before we go into these studies and the clinical trial updates, we talk about, of course, there's the newly diagnosed myeloma patients, and then they have first line therapy, frontline therapy. Then you've got, people who relapse, and then they're trying to figure out what are the right treatments. Where do bispecifics fit in, and what are they being studied for?
Great question. So, the majority of therapies in myeloma always have to start off at the end of the line because we already have proven strategies for newly diagnosed and early relapse. So, all of these studies, CAR Ts, bispecific cell mods, are all slated to be approved in what we call triple class refractory myeloma patients. So, refractory to three classes: an immunomodulatory drug like Revlimid, a proteasome inhibitor like Velcade, and a CD38 antibody like daratumumab. So all of these drugs are going to start off at the end by themselves. Over time, we're going to move them further and further up and potentially combine them. And over time, that they'll probably be either in first relapse or even frontline. So daratumumab started off at the end of the road. It's now an upfront therapy standard in the US. So we always start off at the end and move our way up.
And that makes sense, right? You have proven, so you start off, let's just approve, make sure that this works on its own. And then hopefully the efficacy, the safety, everything, the side effects, they get better as you study moving them up or in combination. Okay, perfect. Thank you, Dr. Richter.